what is the single most critical infrastructure gap we must solve to truly align incentives around patient outcomes. Brad, let's start with you first.
Sure. Happy to start. As mentioned, I'm a primary care doc and a deep believer in the concept of value-based care. This notion that we should be focused not on the individual visit that we're seeing. And I trained in a program that was very focused on preventative health and how do you think about the whole patient. And I think on my first week of being a full-time PCP, I asked my chair, I was like, okay, how do I pull a list of all of my patients that have an A1C above 9? I'm like, oh, we don't have that. That's what do you mean? Why would you want that? And that was maybe 10 years ago or so now. And that infrastructure and the notion that we shouldn't just sort of align around what is the patients that I'm supposed to see today, but who's actually most sick and who's in need of help is, I think, the core notion to me of value-based care and how do we move away from our current reimbursement system based on fee-for-service. I think transitioning to infrastructure side, from my perspective, the biggest challenge in value-based care is the measurement challenge. My perspective, and I promise the Arbital folks didn't put me up to this, is that we spend, I run a value-based care company, and we spend, a lot of our time focused on the care model, and then you spend an outsized amount of time focused on the reconciliation, the methodology. How do we participate in a CMMI model ourselves. How do we try to reproduce what CMMI meant in their 100-page manual document? And trying to get away from spending as much time on the measurement of value and more time on delivering the value is, I think, the next frontier of value-based care. I don't know quite the right solutions, but I have some ideas, and we can talk about those as we go through.
Okay. We've talked a lot, and even the last session, on the issue of data. And I think that's the really critical, important piece of the infrastructure. But it isn't just what we've done with regard to the tremendous progress in acquisition and aggregation of data, and now maybe even the analysis with tools like AI, but really the ability to create that data into an integrated, interoperable system that enables us to move away from what we see as a static kind of view of quality healthcare or value-based healthcare to really more of a dynamic one, going from a snapshot to a motion picture, because we're constantly perturbing the system. We're constantly perturbing the patient and the interventions, et cetera. And we need to be able to track that in a way that enables us to make iterative changes that constantly improve that value-based care.
Yeah, I of course, +1 to both. I think there are 3 things I've got my eye on. We're on the 20/80 of the 80/20 rule in all 3, but we're close to tipping fast. 1, open API networks. You heard Mark say this earlier today with CMS. Payers and providers have to become more transparent with one another about the patient record. And that opportunity to collaborate is like a bedrock assumption in value-based care. Both parties agree to share data with each other, but today it's flat files with some long lag time and in a format that's not usable. So we have the opportunity now to build payer-provider collaboration on a population where we have a little bit more common definition of the patient's 360-degree view. So that's, I think we're going to get a shot in the arm from CMS, but that's needed. And I want to go on where Brad was with open science. The frustration of having to take a Word document and then have your computers interpret the Word document as to what is the adjustments necessary to get to the math leads to my math said it's this, your math said it's that, and we fight over interpretations of a Word document. We need computational contracts. And so open science to me is the parties agreeing on a common ability to adjudicate data from the open API network in this format so that the science that runs on that data can give you the same answer and that we could all agree as to what's happening and we have a little bit more shared understanding and not battling. And then I think, and to give you an example of what just happened last week, CMMI did publish for the first time the risk adjustment logic for the shadow bundles and specialty shadow bundles on their GitHub repository. So you sort of like, 20%, 80%, we're getting there. But I think a little bit of the question that was over here, we need open data. And in this example, open data on steroids to link clinical data and administrative data for the country in a way that's privacy preserving, open, competitive, market enabling, but is respected. LLMs today are trained on the published internet. They are not trained on the longitudinal records of the American healthcare economy. And how we get to learning, I mean, remember in the pandemic, where did we learn about proning as the treatment modality? That didn't come from a US learning health system. That came from Israel, integrated network payer provider that said that this ended up having a higher quality of life extender. So why can't we have nice things? Why can't we be the ones to surface the protocols? Maybe there's a better protocol for GLP-1 use tied to coaching, tied to something, and that protocol should be scaled everywhere. So I think those are the three pieces of infrastructure that I think are critical. And we're close, but we're too early to declare victory. We need a little bit of public action to push us from here to here.